पहिला फिङ्गर फ्लेक्स
भयो छैन
we can do by two method
यो हामीले के गर्दैछौँ
सुपरफिसियल
finger flexion jog deep reflex नै हो
टिप्ने
we can do like this or we can do like this also like this then I will strike I will hold like this I will strike my own finger from below and I will look for flexion of the all the fingers and thumb normal
तर इट विल बी इजी when we
can do like this also
बेडमै रेस्ट गराउने
बेडमै रेस्ट गराएर पामलाई माथि फेस गराउने अनि आफ्नो फिङ्गरलाई चाहिँ पेसेन्टको फिङ्गरमा राख्ने अनि अलिकति यसो बनाउने त्यसपछि आफ्नै फिङ्गरलाई स्ट्राइक गर्ने त्यसपछि फिङ्गरको फ्लेक्सन यसको फ्लेक्सन अब्जर्भ गर्ने अनि यदि यति गर्दाखेरि चाहिँ रिफ्लेक्स आएन भने चाहिँ वी हेभ टु रिइन्फोर्स फर रिइन्फोर्समेन्ट फर लोवर लिम्ब रिफ्लेक्सेसलाई चाहिँ म्यानुभरमा चाहिँ interlocking of the fingers and while the patient interlocks at that time we have to strike at the same time we have to
1 2 3 भन्न लगाउनु नि अनि 3 गर्दा ठ्याक्क स्ट्राइक गर्ने
3 गर्ने बेलामा तपाईले यस्तो
upper limb reflexलाई चाहिँ we have to ask the patient to cleanse his or her teeth and त्यसपछि at the same time we have to strike so now coming to examination of superficial reflex I will check for abdominal reflex then Levinsky then corneal reflex and if feasible we can also do cremastic reflex. For doing abdominal reflex we have to strike the abdomen from outward to inward in 4 direction. And look for the contraction of the abdominal muscle at that time.
अम्बिलिकसलाई सेन्टर पारेर
अम्बिलिकस सेन्टर पारेर
अघि हामीले त्यो जसरी फिल्ड अफ भिजनमा यताबाट गरे जस्तै चार ठाउँबाट बिचमा सेन्टरतिर आउने ल अब प्लान्टर
Now coming to examination of the contour part of the Levinsky in upper limb, we can do Hoffman sign or Hoffman reflex. We'll hold the patient's right hand with our left hand like this, and we'll place our right index finger over the distal interference joint of the patient's right middle finger, and freely strike it downward like this, and look for
pyramidal lesions
and look for
movement of thumb.
The movement of the thumb in case of pyramidal lesions.
In pyramidal it will be adducted.
It will be adducted. And check for we can also check it by doing Warting box sign, in which we keep the patients and our hand interlock in semi-prone position, and we stretch in opposite direction, and we look for the direction of the thumb. Normally it will extend like this. In case of pyramidal lesion, the thumb will be adducted.
प्लान्टर
Now examination of plantar reflex. First of all, we should inspect the sole of the patient's foot, whether it is very thick or not, whether there are any wound or ulcers, or the toes are amputated or not. And we should hold our left hand above the ankle joint, because we should also see that for the ankle flexion, the pec flex. And we have to start from the heel, and we have to go laterally, and we have to strike up to the little toe. We should not cross the ball of the first great toe or great toe. So if by this method we cannot elicit, if we cannot elicit the plantar, then we can go for other techniques. Like we can roll one, slide.
Scene of TV.
Against the scene of the tibia.
Heavy pressure is applied by the thumb and the index finger from above downward to the anterior surface of the tibia. The extensor response usually occurs towards the open him sign भनेको चाहिँ heavy pressure is applied by the thumb and the index finger from above downward to anterior surface of the tibia. This illustrates the extensor response. Similarly, now coming to the Gordon reflex. In Gordon reflex, squeezing or applying the deep pressure to the calf muscle produces extensor plantar response. And similarly, Sauffeur sign. In Sauffeur sign, we need to apply deep pressure over the tendo Achilles, and we see the same response. Similarly, Chaddock sign. Chaddock sign, in which we strike the skin around the lateral malleolus in a circular fashion. And now coming to the Gonda, that is the Chaddock sign. Now coming to the Gonda, in which we just squeeze or stretch the either second or fourth toe, and it will elicit the same response. And now coming to the Bing sign, where we apply by the help of the pin, we prick over the dorsum of the foot, and it also produces the extensor response. Okay. Now briefly talking about the this reflex. Normally, in normal person there is flexor response, and in the now comes to the main disease pathology. In extensor response, it is seen by dorsiflexion or extension of the great toe. That is, movement occurs at the metatarsophalangeal joint, which usually precedes all other movement mentioned below. First of all, first भनेको नै के हो त भन्दाखेरि ग्रेट टोको चाहिँ डोर्सिफ्लेक्सन हो, त्यसपछि चाहिँ फ्यानिङ हो सेकेन्डमा, फ्यानिङ एन्ड एक्सटेन्सन अफ द आउटर फोर टोज है, त्यसपछि चाहिँ अनि डोर्सिफ्लेक्सन अफ द एङ्कल, अनि फ्लेक्सन अफ द नी एन्ड फ्लेक्सन अफ द हिप है, अनि कन्ट्र्याक्सन अफ द टेन्सर फेसियल ल्याटा. इक्विभोकल भनेको चाहिँ कहिले इनकम्प्लिट रेस्पोन्स अर भेरिएबल रेस्पोन्स भनेको वेन अल द फुल कम्पोनेन्ट्स अफ द एक्सटेन्सर रेस्पोन्स इज नट मेनिफेस्टेड, that is खाली only fanning of the outer toes is seen without any movement of the great toe, अथवा hemiplegic side does not show any response and the healthy side shows flexor response in early cases of CBA, or asymmetry of the flexor response in both sides. And when we see no response is after striking the sole of the foot, there is no movement of any of the toe. Withdrawal response भनेको के हो? Often withdrawal response is seen in anxious individual or in a normal person with hyperesthetic or sensitive sole. It is seen that the initial normal flexor response is quickly followed by the mass extension of the toes with the withdrawal of the entire leg. Entire leg withdrawal गरेर जस्तो देखिने भयो. ल सबै यस्तो गरेर